The highland districts of Mokotlong and Thobotsika consistently record the lowest life expectancy figures, with some villages reporting that half of all adults die before age 50. The demographic collapse creates economic consequences that threaten the country's future viability. Lesotho's working-age population between 18 and 60 is shrinking faster than any other country in the world. Current projections show this critical demographic declining by 2.3% annually, a rate that makes long-term economic planning nearly impossible. The textile factories that once provided employment for tens of thousands of workers now struggle to maintain adequate staffing levels as their workforce literally dies away. Current mortality trends suggest even worse outcomes ahead if nothing changes dramatically. Mathematical projections based on existing death rates indicate that life expectancy could drop below 50 years by 2030, pushing Lesotho into territory that would make it the shortest-lived nation in recorded human history. The trajectory appears almost inevitable unless the multiple crises driving early death can be addressed simultaneously and aggressively. Behind these devastating numbers lies a single disease that continues to ravage the population despite decades of international intervention: the HIV epidemic. Progress and persistent challenges. HIV prevalence in Lesotho remains stubbornly fixed at 21.1% among adults in 2025, placing the Mountain Kingdom among the countries with the highest HIV rates globally. This figure has shown minimal variation over the past several years, revealing how prevention programs have reached a plateau rather than continuing the downward trajectory that health experts once predicted. New infections have stabilized at approximately 13,000 annually, a number that neither climbs dramatically nor falls significantly from year to year. Prevention programs face obstacles that extend far beyond simple lack of funding or medical resources. Traditional cultural practices continue to influence behavior patterns despite extensive education campaigns that have run for over 2 decades. Male circumcision rates remain low in many communities, hovering around 42% nationally, well below the 80% target that health officials believe could significantly reduce transmission rates. Cultural resistance to the procedure stems from traditional beliefs about masculinity and concerns about altering practices that have existed for generations. Even when circumcision is performed, it often happens through traditional ceremonies that may not follow medical safety protocols. Multiple partnership patterns persist across various segments of society, creating transmission networks that prevention messages struggle to interrupt. Research indicates that approximately 35% of sexually active adults maintain concurrent relationships, meaning they have overlapping rather than sequential partners. These patterns exist among both men and women, though they manifest differently based on gender roles and economic circumstances. Men often maintain relationships with women in different locations, particularly when work requires travel or migration. Women may enter relationships with multiple partners for economic survival, especially in areas where formal employment opportunities remain limited. The migrant labor system that sends thousands of Lesotho men to work in South African mines creates a highway for HIV transmission between communities. An estimated 45,000 men work in South African mines at any given time, with most returning home every few months for brief visits before departing again for extended periods. This circular migration pattern exposes workers to HIV in mining communities where prevalence rates often exceed 40%, then carries the virus back to rural Lesotho villages that might otherwise have limited exposure. Mining companies have implemented HIV testing and treatment programs, but coverage remains incomplete and many workers avoid testing due to fears about job security. Treatment adherence presents another layer of complexity in the HIV response. While national averages suggest that 78% of people on antiretroviral therapy maintain good adherence, this figure masks dramatic regional variations. Recent studies document adherence rates dropping to just 40% in remote mountain villages where healthcare access requires long journeys over difficult terrain. Patients in these areas often ration their medications, taking pills every other day or skipping doses entirely when supplies run low. The irregular dosing patterns increase the risk of developing drug resistance, while maintaining viral loads at levels that facilitate transmission to partners. Pre-exposure prophylaxis introduction in 2023 represented a significant advancement in prevention technology, but uptake has disappointed health officials. Cultural resistance centers on beliefs that taking medication when not sick violates traditional approaches to health and healing. Some communities view PrEP as encouraging promiscuous behavior or undermining moral values around sexual relationships. Religious leaders have expressed mixed messages about the medication, with some supporting it as a life-saving intervention, while others worry it promotes sexual activity outside marriage. Mother-to-child transmission rates reveal another area where progress has stalled despite available interventions. The current rate of 8.2% exceeds the regional average of 5.4% and remains well above the elimination threshold of 2% that would indicate effective prevention programs. Factors contributing to persistent transmission include late entry into prenatal care, irregular clinic attendance during pregnancy, and challenges with maintaining viral suppression during breastfeeding periods. Rural women often deliver babies at home with traditional birth attendants rather than in health facilities where prevention interventions could be implemented. Political instability since 2022 has disrupted the consistent funding streams that HIV programs require for effectiveness. Changes in government leadership led to reviews of existing contracts and partnerships, creating months-long gaps in service delivery while new agreements were negotiated. The uncertainty affected both international donor relationships and domestic program implementation. Some HIV testing sites closed temporarily due to supply shortages, while community health worker programs experienced payment delays that led to reduced outreach activities. PEPFAR funding reductions have created particular challenges